Alright, let's walk through the zeroing procedure for central venous pressure, CVP, monitoring. If you're a nurse working with critical care patients, you know getting an accurate CVP reading is key for managing fluid status and cardiac function. But as you probably learned early on, those numbers mean nothing unless the monitoring system is zeroed correctly. First up, patient positioning. I always make sure the patient is in a consistent position. Most of the time, that's lying flat, supine. Sometimes your protocol may say semi-recumbent, like with the head of the bed at 30 or 45 degrees. The important thing is to pick a position and stick with it for every measurement. And don't forget, movement, straining, or even heavy breathing can throw off the numbers, so I make sure my patient is calm and relaxed first. Now let's find the phlebostatic axis, the magic spot for zeroing. Here's how I do it. I look for the fourth intercostal space at the sternum, then draw an imaginary line straight across to the mid-axillary line. That's about the middle of the armpit. That intersection? That's my zero reference point. I mark it right on the patient's chest so I don't lose it. Next comes leveling the transducer. I adjust the transducer so the air fluid interface sits exactly at that phlebostatic axis. If it's too high or too low, your readings will be way off. I make sure it's secure, taped to the chest, clamped on an IV pole, whatever keeps it steady at that level. Now, prepping the system. I check that all tubing and the transducer are primed with flush solution, no air bubbles. Then, I find the stopcock closest to the transducer. Time to open the system to air. I turn the stopcock off to the patient and open it to the air. This exposes the transducer to atmospheric pressure. Some systems have a cap or a special port for this. Here's the fun part, in theory. On the monitor, I hit the 0 or calibrate button for the CVP channel. The monitor sets atmospheric pressure as 0, and I'll usually see 0 mmHg pop up. Done? Not quite. I turn the stopcock back, off to air, open to patient, so the transducer is connected again. If I removed any caps, they go back on. Finally, I check the waveform on the monitor. I want to see those classic A, C, and V waves. For the most accurate CVP, I record the number at the end of expiration, when the patient's chest is still. And there you have it, step-by-step zeroing for CVP monitoring. Stick to the basics, stay consistent, and your numbers will actually mean something.